Good morning, everybody. It is my pleasure to introduce our speaker for this morning, who's Dr. Abigail Simmons. So Dr. Simmons is a graduate of Temple University for her medical school, and then was recruited here to Yale and has been a homegrown Yale graduate since then and has been a really standout for us. So she was recruited here to be an internal medicine pediatrics resident. And I remember when she was around third-year resident, she came to my office and said, "Hey, this is pretty cool, this cardiology thing and this adult congenital thing." And she has just taken off and flown from there. So she was an outstanding fellow in pediatric cardiology, presenting her work at national meetings, publishing papers. At one point, I thought she was working on a review with most of the faculty in our section at different times. And when we started to think about the new training pathway for adults with congenital heart disease, which I wanted to take a minute and say thank you in particular to Ed Miller, who was a big supporter of this. We created our inaugural fellow, advanced fellow for adults with congenital heart disease, which is a training pathway where you can qualify for this training either by completing your cardiology, internal medicine cardiology training, or your pediatric cardiology training, and then coming to spend 2 additional years of training. Abigail said, "Sure, I would love to do that and sign up for that." And she's in the middle of her 2-year fellowship and doing an outstanding job. I really look forward to this talk. I think it's going to be very instructive. So, Dr. Simmons, thank you.
Thank you, Dr. Elder. All right. So to begin, I have no disclosures. I will say that I have a difficult job here today, because as it turns out this year, adults with congenital heart disease has been a fairly hot topic here at Yale. So if we think all the way back to one of our initial grand rounds this year, we invited Dr. Bashor from Duke to come and share with us. He presented a case of congenital heart disease and really set the stage for both where we have come from and where we are heading in terms of the care of adults with congenital heart disease. This was followed shortly thereafter by another prestigious speaker, Dr. Ami Bhatt from Mass Gen, who really introduced us to an exciting event that happened for those of us that care for these patients this year, which is the release of the updated guidelines for the care of patients with adult congenital heart disease. Shortly thereafter, Dr. Elder and I had the distinct privilege of addressing the general internal medicine grand rounds community about issues related to general internal medicine in our patients with adult congenital heart disease. And then most recently, Dr. Tom Jones from Seattle came and was the keynote speaker at the 8th annual CME update for interventional cardiology. And the focus of that morning really was the interventional care of our patients with adult congenital heart disease. So I've had a lot of prestigious speakers go before me. And if you had been at any of those presentations, you very likely have seen a slide very similar to this one, with the take-home message that although the population of patients with congenital heart disease that are children has stayed relatively the same over the years, we are witnessing a really rapid increase in the number of adults with congenital heart disease. And that over the course of 1 decade, we saw the proportion of children to adults with congenital heart disease rapidly changing, with more patients with congenital heart disease being adults rather than children. Current estimates are that about 1.4 million adults with congenital heart disease are living in the United States today, and that population continues to rapidly increase, with one study looking at population data predicting that we will be increasing by about 20,000 patients per year, with no expected plateau until at least the year 2050. Our own experience at Yale parallels this. So this is some data that Dr. Elder provided me in terms of our own adult congenital clinic. So looking at total visits per fiscal year, we have an ever-increasing number of patients that are coming to see us. And on top of that, an increasing number of new patients that are coming to see us. And this is certainly very exciting for us, and particularly exciting for our patients, as multiple studies are beginning to show that having access to subspecialty care with providers who have specialized in adult congenital heart disease really has tremendous paybacks in terms of decreasing substantial long-term morbidity and mortality. But I think if we're honest with ourselves, we'll recognize that subspecialty care is a finite resource. So this is a map of clinics in the United States that self-identify as having an expert in the management of adults with congenital heart disease. And at first glance, you might say, well, we're doing pretty good. That's a lot of little red balloons on this map. But as you click on each one, you'll find that most of these practices have 1, maybe 2 cardiologists on staff that have specialty and expertise in adult congenital heart disease, and most of them that's 25% time, 50% time. So if we're thinking about the care of 1.4 million adults in a rapidly increasing population, we're going to vastly outstrip the current workforce. And so we have to be thinking about what is really the right model of care to provide the care that these patients will need as they grow older. And I think a very sort of humbling thing for those of us that practice adult congenital heart disease medicine is to recognize that probably the right way to care for these patients is not siloed, meaning that we're going to create a workforce of adult congenital heart disease specialists that can provide the all-around, wrap-around, comprehensive care for our patients. But in the reality, we're joining a team of experts in adult cardiovascular disease that can also provide insight and subspecialty care to our patients. And so you can imagine that although we may be able to provide insight into the congenital aspects of a patient's heart disease, that we are going to need to draw from the experts in general cardiology, interventional cardiology, ranging from congenital to structural to coronary interventions, heart failure expertise, preventive cardiology, thinking about this population as a whole and the public health challenges that they face, and our colleagues in electrophysiology. So with all of that in mind, and as I thought about what would be the next step in terms of topics that are discussed, I thought it would be helpful to try and be eminently practical. And so I selected a patient population of Tetralogy of Fallot, which is, we would consider one of our moderately complex diseases, and is certainly the most common cyanotic form of congenital heart disease. And a patient population that's going to be increasingly showing up in the adult hospital with relative complications, both related to congenital heart disease as well as to acquired heart disease. And so I thought I would try and leave everyone with 5 take-home points for how to approach the care of this unique patient population, specifically patients with Tetralogy of Fallot, and then also use that as a paradigm for when you're approaching any patient with significant congenital heart disease. So without further ado, point number 1, 5 things to know about patients with Tetralogy of Fallot, sometimes referred to as TETs or abbreviated as TOF, is that not all TETs are the same. Invariably, whenever I come to someone and say, I have a patient with Tetralogy of Fallot, I'd like your help in caring for them, you almost see this immediate glaze come over their eyes as they're hearkening back to medical school days, trying to remember what 4 defects compose Tetralogy of Fallot. My guess is some people in this room are sitting here trying to remember them right now. And so you can just stop, I'll just tell you. It's a VSD, an overriding aorta, pulmonary valve stenosis or some component of right ventricular outflow tract obstruction, and right ventricular hypertrophy. I'm also going to share the best kept secret in pediatric cardiology, which is that very few of us actually think of this disease in terms of 4 defects. We very often think of this heart disease as one primary defect, almost a monology of Fallot, that sets up all the other problems that these patients will have. And what that is relates to this conal septum, also called the outlet septum, infundibular septum, the outlet septum. We have a lot of names that we call things in congenital cardiology. And that developmentally, this septum is deviated anteriorly and superiorly into the right ventricular outflow tract, thereby causing obstruction to pulmonary blood flow. Embryologically, we think that flow promotes growth, and so with that obstruction, there is decreased flow across the RV outflow tract, the pulmonary valve, the main pulmonary artery, and the branch pulmonary arteries, and it sets up the possibility for there to be multiple levels of obstruction to pulmonary blood flow. And that affects the unique anatomy that each patient will have. Because as you can imagine, there's no genetic blueprint saying, I have Tetralogy of Fallot, ergo my conal septum is going to deviate approximately 45 degrees into the right ventricular outflow tract. That there's going to be a range of obstruction that these babies have, and that's going to set up a unique anatomy and physiology that has to be addressed. And so when we approach our patients with Tetralogy of Fallot, a question that we often ask is, what kind of TET are you? Are you like this baby on the left wearing a pink hat where your degree of obstruction is really quite mild? So this is a parasternal short axis view showing this defect. So you have your aortic valve in the middle. You see here a large ventricular septal defect, and that the conal septum here is again deviated anteriorly and superiorly and providing what's really only a modest degree of obstruction really in the subvalvar area. As the clip plays though, you see that the pulmonary valve annulus looks to be of a good size, as does the main pulmonary artery and the branch pulmonary arteries that come in at the later part of the clip. So this baby would be very pink. And as you can imagine, the surgical repair that this child will need is going to be very different from the other child. And these are typically our bluer TETs. So this image is somewhat dark, This is also a view that probably most of you all don't typically look at. It's a subcostal off-axis view, and it allows us to profile the RV inflow, body, and outflow tract. And here in color, we can see again that there's a large VSD here. The conal septum has swung anterior and superiorly and is really significantly obstructing pulmonary blood flow. The pulmonary valve, if we looked at further clips, would be very hypoplastic in this patient, as would the main pulmonary artery. And actually, we even get a hint that in this baby, the ductus arteriosus is still open and may be contributing substantially to the pulmonary blood flow. Similarly, as just one final example of the multiple levels of outflow tract of pulmonary blood flow obstruction that can happen, is a look at this baby's branch pulmonary arteries. So the right pulmonary artery actually looks a fairly good size. But if we look at the left pulmonary artery, we see really at its origin significant narrowing. And again, as I said, this baby, the ductus arteriosus is still open, and it's actually providing the main blood supply to that left pulmonary artery. And this is something that pediatric cardiologists will look for and recognize that really the left pulmonary artery has ductal-dependent blood flow, and if it's allowed to close prior to a surgical intervention, this is a person that may completely lose blood supply to their left pulmonary artery. They're also at risk for a number of other associated abnormalities listed here. But for my interventional colleagues in the room, there's also a significant risk of coronary artery anomalies. So if I ever come to you and say, I have a patient with Tetralogy of Fallot, they're having chest pain, they need a cardiac cath, a left heart cath to look at their coronaries, your next question should be to me, do they have any coronary anomalies that I should know about? So it occurs in about 5% of our patients, with the most common being that the left anterior descending is going to come off the right coronary artery. You can also have situations where you have dual LAD supplies. You can have single coronaries, either single right or single left. And in terms of accessing these coronaries, it's very helpful to know that they are very often clockwise rotated, so a more anterior-posterior dimension, and that their ascending aortas, by the time they reach adulthood, are actually quite dilated, often measuring 4, 4.5, 5 centimeters. We don't tend to worry about that in terms of dissection, but it certainly makes a difference when you're trying to access these coronary arteries. And that leads to the next point, that really their surgical and interventional history matters. So in the same way that many of you in the room think about a person's history of coronary artery disease and the interventions they've had, and how that guides your evaluation of chest pain, so too that's how we think of patients with Tetralogy of Fallot. That it's not simply enough to say this is a patient with Tetralogy of Fallot that was repaired. That's a very non-specific description. That the question really becomes, what repairs have they had, what interventions have they had, and what residual structural disease may they have that will impact their future complications and the care that they need. So I want to actually present a case that illustrates this. This is a patient I saw in clinic actually last week. She's a 68-year-old lady. She was coming actually for her first adult congenital heart disease visit ever. She's been having fantastic care by one of our community cardiologists. She reports being born a blue baby. So she was born at a date and time where we didn't really have echo. We just made the diagnosis by physical exam and the fact that the baby was blue. She managed to survive, but she does report having severe dyspnea all throughout childhood. And she actually described, she said, I would run and then I would squat because I was so short of breath, and that seemed to make things better. She had her first intervention at the age of 4, and she had another intervention at the age of 11. She can't really tell me much of the details of those, but that they did improve some symptomatic improvement. And then she finally had a complete repair at the age of 17. Following that, she said, I really did great. She said, I went from being severely exercise limited to having really no symptoms at all. And she was really excited to tell me about the fact that she went on her high school trip to Washington, D.C. and was able to hike around with her classmates, and that was something she'd never been able to do before. She ended up in our clinic because her outpatient cardiologist was providing guideline-driven care and put a Holter on her, and it showed new episodes of atrial fibrillation. And they asked the question, is this something related to her congenital heart disease, and do we need to do anything different in terms of caring for her? In terms of exam, she had bilateral thoracotomy scars, she had diminished radial pulses, she had a sternotomy scar, and she also had a systolic ejection murmur with no diastolic murmur. And we checked her blood pressures. The blood pressures in her arms and right and left arm were actually quite low. So her history is really reflective of the whole history of the surgical management of Tetralogy of Fallot. So in 1944, we were able to offer the first intervention for these babies, and it wasn't a repair. Remember, as I said, the main problem physiologically that these patients face is really trying to increase the amounts of pulmonary blood flow and that they have obstruction to pulmonary blood flow. So some very smart individuals thought that what we could do is utilize the subclavian artery as a shunt to augment pulmonary blood flow. And so at the time of surgery, the subclavian artery would be dissected out. to typically a branch of the vertebral artery so that there could still be some flow to the arm, and then would be turned down and anastomosed to the pulmonary arteries in order to provide more pulmonary blood flow. This would explain the bilateral thoracotomy scars on this patient. This is an important piece of information to know for patients that have had this procedure in the past. One, again, if I asked you to do a left heart cath on them and you're thinking about radial access, that's probably not going to work. But two, that intervention also sets up the possibility for future stenosis of that pulmonary artery, as it gets tethered and tented upwards and can become significantly stenosed and obstructed. And so something that we would routinely screen for in terms of our follow-up imaging on these patients. Once we began to have durable repairs of tetralogy of Fallot, there's a number that I think about and that help me understand what risk a patient is at. So the first is a very simple repair, a valve-sparing tetralogy of Fallot repair. And this would really be most likely what the first baby that I showed you, the very pink tet, the repair that they would have had, which is where we would simply close their VSD with a patch and resect any of the infundibular muscle that may be causing some obstruction to pulmonary blood flow. We would try and leave the pulmonary valve as intact as possible, perhaps doing a valvotomy to increase its opening, and we would try and leave the main pulmonary artery and the branch pulmonary arteries alone. That's a very simple repair with very simple congenital heart disease. More complicated patients, however, may have more complex outflow tracts. So in some cases, usually when there's a coronary artery that's crossing the right ventricular outflow tract that limits the surgical approach, the patient may have an RV to PA conduit. These conduits run into a number of complications. They are subject to increasing stenosis over their lifetime and also pulmonary insufficiency. Finally, our most common repair that we would see would be a transannular patch repair. And again, there's different versions of this, but they all have essentially the same components, which is that the main pulmonary artery, an incision is made there and carried down through the pulmonary valve annulus into the right ventricular outflow tract. The whole area is then splayed open, a patch is sewed on to relieve the obstruction. The end result of this, however, though, is that the pulmonary valve is rendered completely insufficient. And so from a very young age, these patients will have free torrential pulmonary insufficiency that will have hemodynamic implications for them as they grow older. The point of all this is not that you should become experts in the individualized surgeries that each patient have. I think that the point of all this is that when you are faced with a patient with tetralogy of Fallot, the question to ask an adult congenital specialist is really, what type of TET am I dealing with? Is this a very sort of simple tetralogy patient who's maybe had one surgical repair, they have very limited residual structural disease, and maybe at less risk for future complications? Or is this a really complex tetralogy patient who's required multiple interventions throughout their life and is setting them up to have significant residual structural disease and a high risk of congenital complications? Because in this patient population, the onset of new arrhythmias, new heart failure symptoms, is very often a manifestation of significant structural disease that should be addressed. And so that's how I think of them, and I think it are two very important starting points for when you face these patients with tetralogy of Fallot. Moving on for my electrophysiology colleagues in the room, is that arrhythmias are a significant concern for these patients, and that we should really beware of sudden cardiac death, even in the best of tetralogy patients. It's our first case. This is a 28-year-old patient who Dr. Elder saw in clinic. He was diagnosed with tetralogy of Fallot at age 2. He had his first surgery at age 2.5 years. So again, from the get-go, you can anticipate that he probably didn't have that severe of disease that he made it to 2 years of age before anyone even sort of noticing that he had heart disease. He was otherwise well. And in fact, so well, he was lost to follow-up, which is a common story with many of our patients. He represented to care at the age of 28 because he developed these episodes of a sinking feeling in his heart. We did our standard echo and found much of what we expected, that the RV was quite healthy, there was no pulmonary stenosis, there was no pulmonary insufficiency. So in summary, he was a really, really, really good TET that we wouldn't think should have a lot of problems. Again, providing guideline-driven care, we put a Holter on him and saw something we didn't expect, that he was having multiple runs of non-sustained fast ventricular tachycardia. He ultimately ended up having an ICD placed. So what do we know about arrhythmia and the arrhythmia burden in adults with surgically repaired tetralogy of Fallot? So this is a classic paper from 2010 looking at a number of patients. They found an overall prevalence of 29.9, so 30% of adult tetralogy patients have a history of a sustained tachyarrhythmia, and about 15% of them are going to be ventricular arrhythmias. We see that at around the age of 45, there's a marked increase in the risk of arrhythmias, both atrial arrhythmias as well as ventricular arrhythmias shown here in the red line. Risk factors for this that this paper identified were really increasing numbers of cardiac surgeries. So as you start to have 1, 2, 3, 4, 5 reduced sternotomies and ventricular incisions, your risk of arrhythmia goes substantially up. They also found, interestingly, that LV diastolic dysfunction was associated with an increased risk of ventricular tachycardia and ventricular fibrillation, providing some insight into us in terms of which patients would benefit from more aggressive management of arrhythmias. So again, turning back to our 2018 guidelines, they call to mind and call to our attention the fact that sudden cardiac death happens at a rate of about 2% per decade and accrues over time in our patients with tetralogy of Fallot. And so primary prevention AICDs are really part of the discussion. Unfortunately, the risk stratification for our patients really remains imperfect. The guidelines suggest that if you have several risk factors, it is something that we should be thinking about. And the risk factors that the guidelines identify are LV dysfunction, non-sustained VT on ambulatory arrhythmia monitoring, a prolonged QRS, or if you have extensive fibrosis on an MRI. Point number 4. Although I spent most of this morning talking about problems of multiple levels of obstruction of right heart function, it's not just a right heart problem. So another patient, a 38-year-old patient, also with tetralogy of Fallot, was repaired as an infant, and he had a transannular patch. He also was lost to follow-up since he was a teenager, and he presented early in the morning to the emergency department with several months of worsening dyspnea and insertion and lower extremity edema. I happened to be the fellow on call that night, so I came in from home to do an echo in the emergency department, and quite honestly, I found exactly what I thought I would find, was that he had a transannular patch, he had free pulmonary insufficiency, and that he had a really dilated RV. So I recognize that this echo picture is upside down for many people in the room, but in congenital heart disease, we actually do try and image in an anatomical way. So this is his RV at the bottom of the screen, which we can see is quite dilated. We see that there's not really any pulmonary valve tissue here that we can see. His MPA is quite dilated, as are his branch PAs. And when we put color in that area, we see that the pulmonary insufficiency is just torrential. What I didn't expect to see as I moved on in his imaging was that his LV was actually quite sick. He had fairly moderately to severely decreased LV function. So LV systolic dysfunction in adults with impaired tetralogy of Fallot occurs in about 21%. So not our most common complication, but something that certainly happens. And that a primary risk for that is RV dysfunction. So just as we see in patients with primary cardiomyopathy, that as the LV fails, so does the RV, we also see in tetralogy patients that as the RV becomes more dysfunctional, it increases your risk of LV dysfunction. This was a paper looking at other risk factors, and I think none of us would be surprised that the traditional risk factors for LV dysfunction are also present in these patients that have a significant decompensation in terms of LV function, meaning any atherosclerotic risk factor, diabetes, obesity, hyperlipidemia, are all the risk factors that this is going to be a tetralogy patient that may have systemic ventricle dysfunction. And that turns out to be a very bad prognostic sign for a patient, that the survival of patients who develop LV dysfunction, shown in red, is significantly decreased in compared to their counterparts who are able to maintain normal LV function throughout their lifetime. So for this patient, we sent him to the cath lab to look at his coronaries. Not surprisingly, in that he was quite young, they were normal and not the source of a problem. We optimized him from a hemodynamic standpoint. He had some uncontrolled hypertension. We managed that, started him on a good regimen of diuretics, and then really began to ask ourselves, what are the next steps in caring for him? We started to wonder about the role of pulmonary valve replacement for him, given his severe pulmonary insufficiency. So the 2018 guidelines, again, provide us a really helpful rubric in thinking about which patients we should be considering pulmonary valve replacement for when they have severe pulmonary insufficiency. So certainly if you have severely decreased LV or RV function, that may be a patient that if they're too far gone and we need to start thinking about advanced heart failure strategies for them. But if you have moderate or more pulmonary insufficiency and you develop symptoms, it may be that the time has come to replace your pulmonary valve. For this patient, you could ask, though, were his symptoms due to LV dysfunction or RV dysfunction, and is really replacing the pulmonary valve going to help his congestive symptoms? Well, in case there was any doubt, the guidelines actually also suggest that if there's LV dysfunction, we should be replacing the pulmonary valve to try and provide the best possible hemodynamic milieu for this patient to function. And so we did. In our lab, we practiced rotational angiography so that we can get a better sense of the 3D anatomy of the right ventricular outflow tract, because landing valves in this area can be somewhat complicated, and we have to make sure there is a good spot for the valve. Our patients with transannular patches, however, don't have an annulus to put that valve in. So we pre-stent the right ventricular outflow tract to create a landing zone for the valve. And in this movie here, you can see the valve going up within the stent that had been pre-placed in the right ventricular outflow tract. And this is a follow-up angiogram showing that this patient now has a competent pulmonary valve. And what was the result? So I'm happy to say that his echo 1 year later shows a marked improvement in his LV function and that he's virtually symptom-free at this point. Which leads me to my final take-home point, that pulmonary insufficiency in this population matters. When patients develop symptoms, it's time to begin thinking about intervening on the pulmonary valve. But the ongoing questions are really, what is the optimal time? And the time of when to address it is really a matter of ongoing discussion amongst adult congenital circles. So we are tasked with a really challenging position, that we manage both severe valvular disease in an older population, where my goals of care may be very different, from a much younger population. So again, if we go back to this 38-year-old person, since he was an infant, he's had severe pulmonary insufficiency, his RV has had progressive dilation, and is it really the right thing to do to leave him that way, even in the absence of symptoms, for 30, 40, 50 years? I think logically, most of us would say that that doesn't make sense, and if you could make this better, we probably should intervene. The question is really when, because we probably shouldn't do it too soon, but we really shouldn't do it too late. And this is really the crux of a lot of discussions amongst providers for this patient population right now. So pulmonary valve replacement is a hot topic amongst adult congenital cardiologists. This was a paper, a meta-analysis from 2013 that did a lot to stimulate this discussion. So they were able to show, one, that the mortality and the risks of doing a pulmonary valve replacement are quite low. The 30-day mortality is acceptable, the 5-year mortality is acceptable, and the redo rate is also fairly acceptable. And what were the benefits that they were able to show looking at a number of studies? That doing a pulmonary valve replacement, again with the summed analysis here at the bottom, showed that we could substantially decrease the RV end diastolic volume. They also were able to conclude that we were able to substantially increase LV ejection fractions, and that we could substantially decrease heart failure symptoms. So to summarize it, we can make the RV look better, we can make the LV work better, and we can make patients feel better. So it sounds like a win, something we should be thinking about and doing for our patients. The question, again, as I've alluded to, is when and what's the right time. So this is a 2018 paper that used the data available in the indicator cohort. I think it's worth pausing at this point to say that research in adult congenital heart disease and congenital heart disease in general is a challenge, that we really have a paucity of registries of patients that can provide us the large data that is often seen in more typical adult cardiovascular studies. So even in this large multi-center international cohort, there were still only about 450 patients that met inclusion criteria, so we're still working with relatively small numbers. And the outcomes they looked at were death, sustained VT, or aborted sudden cardiac death. And only 36 patients had those primary outcomes as listed here. What this study looked at was trying to see which patients had their pulmonary valve replaced and still didn't do well, and could we identify risk factors that may help us identify what the right time should be for sending a patient for a valve replacement. And they found three, that they were a decreased RV ejection fraction, significant right ventricular hypertrophy, and interestingly, an age of pulmonary valve replacement greater than 28. That all of those held up both for all death causes of mortality and cardiac causes of mortality. And not only that, they were cumulative. So as patients acquired each risk factor, their long-term survival following pulmonary valve replacement was decreased. So they started to provide for us some targets that may say that these are patients that we've waited too long to replace their valve, and that we're not going to provide a substantial mortality benefit to them. So is that the message? That if you reach the age of 27, you haven't had your pulmonary valve replaced, you're otherwise healthy, that happy birthday to you, we will be sending you to the cath lab or to the OR to have your pulmonary valve replaced. In all things in medicine, there's another side to the story. So this is another very clever and interesting paper, also published in 2018, also using the same cohort of patient, the indicator registry. And they looked at trying to say that, well, just because you have a risk factor for a poor outcome, does actually replacing your pulmonary valve replacement protect you from that outcome? It's a logical question. So they looked to determine the association of pulmonary valve replacement in repaired tetralogy of Fallot patients with freedom from death, sustained VT, and aborted sudden death. And they tried to determine if there was any benefit to patients having a pulmonary valve replacement according to either a proactive set of guidelines that would guide pulmonary valve replacement or a more conservative set, shown here. So if you were going to do a very early aggressive pulmonary valve replacement, these were patients that had their valve replaced at smaller RV volumes with normal RV ejection fractions, normal LV ejection fractions, basically fairly healthy tests. As compared to a more conservative group where their RVs were somewhat more dilated, they may have some RV systolic dysfunction, they may have decreased LV function. And what did they find? The other very clever part of this study was that they did a propensity score adjusted analysis. So what that meant is they, to the best of their ability, matched the patients in the cohort. So they took a very sick tetralogy Fallot patients and looked at those patients and saw who had pulmonary valve replacements and who didn't have pulmonary valve replacement, and was there different in outcomes based on their underlying comorbidities. The results were somewhat disappointing, honestly. So when they looked at the matched cohort, so again, comparing a really sick tetralogy patient who had their pulmonary valve replaced with one who did not, they really failed to show that pulmonary valve replacement made a substantial difference in terms of their morbidity and in terms of their mortality. So we didn't make a difference in terms of their risk of death, VT, or aborted sudden cardiac death. Furthermore, when they looked at the criteria, so again, the criteria are down here, so the early aggressive pulmonary valve replacement strategy and the more conservative pulmonary valve replacement strategy, the patients, only when you started to meet the conservative criteria did you even start to see a signal that perhaps you were making a difference in terms of their mortality. Not statistically significant, but potentially a signal. And more concerning are these two dots over here, which are for the patients that didn't meet either the proactive criteria or the conservative criteria, that actually we were starting to potentially cause them harm. So taking very healthy tetralogy of Fallot patients and doing your pulmonary valve replacement too early, too aggressively, may actually increase their risk of the primary outcome. Again, not statistically significant, but a marker that we have not yet figured out when the right time is to do this for this patient population. So in summary, they really couldn't show that pulmonary valve replacement decreased morbidity in this, mortality in this patient population, and that early pulmonary valve replacement may be associated with increased adverse events. I think there's some caveats to the study, though, that are worth mentioning before we just throw pulmonary valve replacement out the window for younger patients. So there's the typical ones that this wasn't a randomized study. Patients got the treatment that their providers thought was the right thing for them. They certainly most likely had insufficient power given the very low event rate. I think it's worth also considering the ages of the patient in the study. So patients that had their valves replaced all had them done within 1 year of their sentinel cardiac MRI. So the average age of the patient having a pulmonary valve replacement was 27. And we see that the patients that had the primary outcomes tended to be older, and the ones that didn't tended to be younger. So you can imagine if we're replacing pulmonary valves at the age of 27, and the previous slides I've shown really show that the events of VT and death are starting to take off around the age of 45, when you've only had 5 years of follow-up, we maybe haven't had enough time to really see the impact and the benefit of that intervention on them, and that the data that's going to come out 10 years from now, 15 years from now, may actually show the benefit of this intervention. The other problem with the study is that it really doesn't reflect the current landscape of pulmonary valve replacement in our patients. So in this study, 90% of the valves were surgical pulmonary valves that were placed in, and only 10% were transcatheter pulmonary valves. And you can imagine, as the previous slides have shown, that increasing numbers of sternotomies increase substantially a patient's morbidity and mortality associated with their congenital heart disease. And so it's not hard to imagine that patients would have post-op complications of ventricular tachycardia, heart failure symptoms, arrhythmias that would impact the numbers that were found here. So I think the jury is still out. To drive this transcatheter pulmonary valve replacement sort of theme home is some of our Yale data. So this is the numbers of pulmonary valve replacements done at Yale New Haven Hospital between 2007 and 2016 with the advent of the transcatheter valve shown here and here. So prior to transcatheter valve therapy, all of our valve replacements were surgical. Once the transcatheter valves became available, we don't really see a tremendous difference in terms of the surgical volume, but we see a tremendous impact in terms of the transcatheter volume. So more and more patients are having pulmonary valve replacements. And I think this speaks to the overall community sense that a transcatheter intervention is somewhat less of a burden to a patient than a surgical intervention. And that spending one day in the hospital as opposed to recovering from a reduced sternotomy, repeat exposure to cardiopulmonary bypass is very different. So I think the data in terms of pulmonary valve replacement for tetralogy patients is really still to come. And I think in the end that we're going to find that there's a window where doing a pulmonary valve replacement too young sets you up for frequent complications and redo procedures, and doing it too old fails to really yield a substantial benefit. And that we're really still in a phase of finding out where that sweet spot is for providing this therapy. So in closing, I'll summarize what I've said, that each tetralogy of flow patient is unique. We should be aware of that as we approach them. The surgical, the interventional history matters in terms of what complications they're at risk for. Arrhythmias happen, we should screen for them. It's not just right-sided disease, that LV dysfunction can actually be a sign of severe pulmonary insufficiency or severe residual congenital disease. And that pulmonary insufficiency really does matter. So in closing, I thought I would share the conclusion of the 32nd Bethesda Conference, which almost 20 years ago considered the plight of the adult with congenital heart disease and really laid out guidelines and challenges for the management of these patients. And their conclusion was that considering the human and financial resources that have been expended in nurturing these individuals to an adult age, so the hard work of my pediatric cardiology colleagues, congenital surgeons, spending tremendous effort helping them to survive, it is extraordinarily important that we improve our systems of care for adults with congenital heart disease in order for them to maintain the functional status that has been won at a great price. Thank you.
Really nice job. I think we have some time for questions, so I'm going to open this up to the audience. Dr. Mani.
Very nice talk, and as you mentioned very nicely, is a bronchial septal defect is the main defect there, which is obviously at least partially muscular defect. And when you look at the genetics of this disorder, look at it, these are all transcription factors involved in development of the heart, entire heart, from NKX 2.5 to jagged 1 to GATA 4 and 6. So I wonder, actually, would you expect a lot from repairing your pulmonary artery in a disease that actually caused by general myocardial disease, and you may not reach that goal because it's actually a generalized cardiac disorder?
Yeah, I think that's a fantastic point. Something I didn't mention was realize there's a significant genetic component to tetralogy of Fallot, and that's a field, cardiogenetics, that we're just now starting to break open. That, you know, we think that we've identified all of these residual structural problems, hemodynamic problems that are causing these poor outcomes, and that probably for many of these patients there's a significant genetic component that we're just better understanding. And certainly every year we find new reasons to potentially find this.
So perhaps a corollary of that question, you have enough data. Have you studied the remodeling of the RV after your transcatheter pulmonary valve replacement in terms of function, volume, scarring, natural history? So
that's, again, an ongoing area of research. I think we can fairly significantly show that we can usually cause the RV to shrink. We can't always get the function back. Some of that is anecdotal data, but more and more series are being published showing that RV function doesn't necessarily recover following pulmonary valve replacement, which sort of has added to the exigency of the discussion of saying we should be doing this sooner to preserve RV function rather than later.
What's the longevity of the transcatheter pulmonary valve, or even a surgical pulmonary valve? I mean, I presume they were all mostly biological or bioprosthetic valves.
So all bioprosthetic valves, so not lifelong. And again, something that I think weighs on our minds in terms of what's the right intervention for this patient, whether it's a surgical valve or a transcatheter valve. I think the general research would say that the longevity is the same, but I think our anecdotal and our Yale experience has really shown that our transcatheter valves are far outliving surgical valves. So there is some data to discuss that. And Dr. Asmus, I don't know if you want to comment on that.
We actually looked at our data, sort of in a similar how you define valve function. So if you, in the older literature on right heart valve replacement, it was really when a surgeon decided the patient needed a new valve, that was when you had valve dysfunction. It didn't really take into account the imaging. If you take into account the imaging, those valves tend to have some degree of dysfunction that's a significant degree within about 5 years. The transcatheter valves, both in our experience and also in the clinical trials, were out to 9, 10 years with really excellent function of those valves and minimal need for reintervention. Some of those valves are being implanted in young kids who are still growing. So in some cases, the valves are outgrown, but then we're able to either redilate or implant a new valve within that structure. So it's not truly dysfunction, it's more somatic growth.
I was really interested when you were talking about your case of the 60-year-old that we saw that had the bilateral shunts and then the new atrial fibrillation. I was wondering, how do you think about acquired heart disease and congenital heart disease, and how should we be ideally approaching these patients in clinic with those issues to prevent those issues?
So that patient actually presented a unique challenge that we talked about. So with bilateral BT shunts that were classic and sacrificing her bilateral subclavian arteries, it's actually very difficult to know what her blood pressure really is because they're going to be very inaccurate. And so checking leg blood pressures in that patient, her leg blood pressures were actually systolics of 180, 190. There's not a lot of norms in terms of what a normal leg blood pressure should be, so that provides a challenge of saying, well, how do I treat to a goal leg blood pressure? Do I presume that she must have some hypertension and that might be a driver for her atrial fibrillation? We honestly don't know the answer to that question. So she had both some risk factors with acquired heart disease as well as her congenital heart disease that complicated that. For her, also, it would be very difficult to, if she presented with heart failure symptoms, again, to access her coronaries radially, we would have to certainly go from the groin for her. So really, that's how I think of her.
So you touched on it with this case, but didn't mention it in a broader sense, that atrial arrhythmias are often more of an issue and a challenge for these patients than ventricular tachycardia, which we've learned over the years. And the other thing is many of these patients don't get our usual preventative care in terms of lipid management and blood pressure with those challenges as well.
Yeah, I think so. And I think that really drives home the team aspect. It's saying, the LV dysfunction, the same cardiovascular risk factors are present, but these patients are having LV dysfunction at a much younger age where, honestly, really how many 30-year-olds do you have in your practice that you're going to be actively screening lipids, trying to aggressively control them, really looking for high blood pressure and aggressively managing those risk factors, and that maybe that actually is something that we should be doing. And even we as adult congenital cardiologists saying, we should be checking their lipids. There may be indications for early statin therapy, and really the traditional models of asymptomatic cardiovascular disease don't fit this patient population, and we should be more aggressively looking for and managing those problems.
Can you tell us a little bit about management in the pregnancy for those who have had corrective surgery? And what are those?
Yeah, that's a great question. So that's actually a time period where many of our women with tetralogy Fallot come back to care, that they've been lost to follow-up, now they're pregnant, they see a maternal fetal medicine colleague who says, wow, you have congenital heart disease, you really need to come back to care. Tetralogy Fallot is fairly well tolerated in pregnancy. Even if they have free pulmonary insufficiency, the afterload reduction that happens with pregnancy tends to be fairly well tolerated. So we would tell patients sort of probably unless they have severe RV dysfunction, that being pregnant is something that's very reasonable for them and we can get them through. We are very fortunate at Yale to have a very close collaboration with the maternal fetal medicine department. So a patient with tetralogy of Fallot, we would typically see once each trimester if things are going well, follow their echoes because there is some risk that they would develop LV dysfunction in the course of their pregnancy, so we'll follow that. We also do a lot of counseling with them about the risk for the baby. So we know that the incidence of congenital heart disease in the general population is about 1%, but when you have an affected parent, your risk goes up to about 5%. So that's enough for us to say you should have a fetal echo to better understand if the baby has congenital heart disease. And surprisingly enough, that really can be any congenital heart disease. So just because mom has tetralogy of Fallot, baby could have an ASD, they could have VSD, they could be a hypoplastic left heart syndrome. Really, it's the whole spectrum is open. So there's a lot of counseling in terms of risk with the baby and follow-up afterwards. But pregnancy in general for tetralogy of Fallot is well tolerated, but should still have some input from a congenital cardiologist.
Right. Thank you very much.